Hey guys, I have a challenge, a little extra credit challenge to start off today's knee notes with. My challenge for you is I want to see who's our best juggler in class. So I'm going to set up a class discussion on Canvas, and there's some links that will show you how to upload a video. But if you upload a video of your best try at juggling, you can choose any three objects that you would like to juggle with, upload your video onto the Canvas discussion, and I will give you extra credit in sports medicine. All right, so find three objects. Any three objects. I'm in the kitchen. I got lemons and limes, and I want to see who can juggle and who can juggle the most times. So we'll do that. Get some extra credit if you post that on the classroom discussion. Don't know how to juggle? Not a problem. YouTube can teach you. Don't know how to post a video to Canvas? YouTube can teach you that as well. All right, so today we're going to be talking about osteoarthritis. So sometimes arthritis and some of the long-term things after these injuries, many of the injuries that we've talked about, arthritis is inevitable for those people, or a very, very high chance they will develop arthritis over time. Some people will develop this osteoarthritis within months after an injury, and other people it may take 5, 10, 20, or 25 years for the arthritis to develop. What are some signs and symptoms of osteoarthritis? Osteoarthritis is also known as DJD, or degenerative joint disease. Some symptoms would be pain that increases with activity, and then it gets better with rest. The knee is stiff. There may be an antalgic gait. Here's a video of an antalgic gait that you'll... Let's try that again. So one knee, this knee is stiff. It doesn't bend. So that would be what an antalgic gait is. Chronic swelling of the knee joint. And this could really be in any joint. We're talking about the knee in this unit, but this would be osteoarthritis for any of the joints. It could be the ankle, it could be a shoulder. Joint tenderness, so palpating or feeling along that joint line is going to produce pain. Osteophyte forms. Osteophytes are these little pieces of bone that start growing off the ends of your tibia and your femur here. And that's just something natural that happens when your body is trying to protect itself. It knows there's a problem in the joint there, so it's trying to lay down more bone to kind of distribute some of those forces. Joint space narrowing, so that space between the femur and the tibia becomes smaller and smaller and tighter and tighter. Loss of range of motion. And crepitus. Crepitus is a grating, cracking, or ratcheting feeling, and sometimes it's even a sound as well. Our next slide, we're going to watch a 4-minute video on osteoarthritis in the knee.
Osteoarthritis is the most common form of arthritis and affects millions of individuals. It is classified as mild, moderate to severe. It affects many parts of the body, including the knee. The knee joint is made up of the femur, tibia, patella, along with the synovial membrane, which contains synovial fluid. Synovial fluid acts as a lubricant in the knee joint. The end of the femur is covered in articular cartilage, which moves against the articular cartilage of the tibia. In a healthy knee, the articular cartilage is smooth, without fissuring, and the bone is smooth.
That's the pearly white, the articular
The
cartilage.
synovial fluid is viscous, aiding in lubrication. The knee can move through its range of motion without pain. Over time, osteoarthritis affects the bone, cartilage, and synovial fluid of the knee. With mild knee osteoarthritis, you will begin to have discomfort in the knee joint. Though the joint space appears normal, the cartilage matrix has begun to break down from a combination of wear and tear and increased production of degrading enzymes. In addition, bone spurs, known as osteophytes, may begin to develop on the edge of the joint. These small, smooth, dense growths of bone are part of the body's natural response to the loss of cartilage. Progression of the disease may be slowed at this stage by increased exercise and weight loss. With moderate knee OA, changes in the joint are much more evident. The cartilage surface between the bones has begun to erode, narrowing the gap between the femur and the tibia. Hyaluronic acid, which helps synovial fluid lubricate the joint, is now becoming less viscous, elastic, and concentrated. Osteoarthritis often affects the subchondral bone, located just underneath the cartilage. Subchondral bone provides hydration and oxygen to the cartilage. As subchondral bone flattens and tries to repair itself, cytokines and proteins are released into the synovial fluid. Osteophytes may increase in number and size, making the bone rougher. All these factors combine to make joint pain more severe and long-lasting, both with movement and at rest. Weight loss and exercise, pain relievers, HA, or steroid injections are commonly prescribed treatments. With severe OA, conditions worsen dramatically. The joint space has become far narrower, causing more rapid and severe destruction of the cartilage. The knee becomes inflamed and sore. Synovial fluid is decreased, increasing friction and pain during movement. Within the synovial membrane, destructive proteins are produced which further degrade cartilage and soft tissue around the knee. Osteophytes continue to develop. Bone moves against bone, not cartilage. Mobility, activities of daily living, and quality of life are severely impacted. Treatment for severe OA is typically surgery by receiving a partial or total knee replacement. If you are suffering from knee osteoarthritis, speak to your physician to discuss.
Stop it there. Risk factors for osteoarthritis. The big reason that we're talking about osteoarthritis during our sports medicine unit and our knee unit, which we're talking about injuries, is one of the big causes of osteoarthritis later in life is some type of traumatic injury when you were younger. Some people develop osteoarthritis within months after their injury has happened and they've had some type of major surgery. Other people, it may take 5, 10, 15, 20 years before they develop this osteoarthritis, this debilitating. So traumatic injury is a big cause of osteoarthritis today. Age is another reason. Through age, articular surfaces, the cartilage in our knee joints and all of our joints can start to break down over time just because of age. So that's why you have a lot of older people that do have knee replacements because of this osteoarthritis, just degeneration over time, even if they haven't had a traumatic injury. And obesity is another risk factor for osteoarthritis. If you have more weight that you're carrying around throughout your life, you're going to put more stress on these joints of your body. Treatment for osteoarthritis. There's a couple of categories of treatment. Some are non-surgical, and then some are surgical treatments. The first ones are non-surgical, so weight loss and exercise. And a lot of the exercise is low impact or no impact exercise, such as walking, biking, swimming are all good exercises for people who have osteoarthritis. Weight loss, so there's less pressure on the joint, less weight going through the knee or the hip or whatever the joint may be. Physical therapy is another treatment option for osteoarthritis. NSAIDs are non-steroid anti-inflammatory drugs such as ibuprofen. And the next category, or the next one is injections. There's 3 different injections that we're going to talk about. The first one is called HA, or hyaluronic acid. It's a viscose supplement, which is just kind of a thick fluid that they're going to inject into the joint, and it's going to lubricate the joint so that the knee moves more smoothly is the goal of HA. The next one is PRP, or platelet-rich plasma. Platelet-rich plasma, the goal is to stimulate some growth and maybe get some of that articular cartilage to possibly grow back on its own. And the third type is cortisone, or a steroid injection. These are powerful anti-inflammatory drugs that are injected into the knee. And the other options are surgical options. Before we talk about the surgical options, we're going to look at what platelet-rich plasma injections are. This is a centrifuge machine. What they do is they take blood out of your body, probably from your arm. They're going to spin it in the centrifuge until you get down to just the platelets left. It looks something like this. They're going to use this syringe with a long needle and inject that into your knee or whatever joint might be causing the trouble. Platelet-rich plasma therapy uses injections and concentrated people's own platelets to accelerate healing. This can be done to accelerate healing of ligaments, tendons, muscles, or joints. PRP injections use each individual's patient's own healing system to improve musculoskeletal problems. So essentially, PRP is an attempt to biologically boost the healing process. Surgical options for osteoarthritis, or OA. I have 4 of them here. Microfracture is one that has been around for quite a while. In microfracture, we're going to watch a short video here, but here's a picture of a scope picture of microfracture where they're going to go in and poke little holes into the bone. Autologous chondrocyte implantation, MACI would be a term. Matrix-induced would be a term used there. Osteochondral autograft transfer, or the OATS procedure. And the last one is osteochondral allograft, which is an OCA procedure. So let's watch this quick video on microfracture.
The surgeon begins by creating 2 portals, or small incisions, in the front of the knee. The arthroscope is inserted through one portal, and a passport cannula is inserted through the other. The articular cartilage injury in the knee is identified and probed. An arthroscopic shaver, or burr, is placed inside the knee through the cannula. The area of diseased cartilage is smoothed with a shaver down to subchondral bone. A rim of stable cartilage is created around the lesion, and a chondral pick is inserted into the knee. The pick is used to punch small holes in the bone where the lesion is located. These holes allow blood from inside the bone to cover the defect. The blood forms a clot over the area of injured articular cartilage, and this clot is slowly converted to a different form of cartilage, covering the defect.
All right, so that's what microfracture is. Our next slide is a representation in animation of osteochondral allograft. This is specifically a bio-uni, so it's the shape there. They can be dowel methods, so they're circles. This one is an oval shape. I believe this is a 4-minute video that we will watch.
The bio-uni osteochondral allograft transplant system provides a new and effective treatment option for elongated defects of the articular surface. Choose a sizer that fits best over the defect area and mark the area to assist in identification of the restoration area. The sizer is then placed on the surface of a fresh osteochondral allograft and advanced over the surface to locate and identify a flush fit. Once the harvest locations have been identified and marked, the allograft is secured in the allograft
So this
OATS
is the cadaver
workstation.
femur.
An oblong cutter and insert are acquired from the instrument tray and assembled. These instruments are placed over the marked area on the allograft, and a Steinmann pin is advanced into the guide pinhole and through the allograft. The impactor handle is attached to the oblong cutter, and the assembly is advanced into the allograft cartilage and bone to the appropriate depth. The impactor handle and Steinmann pin are removed from the oblong cutter, and a distractor tool is utilized to remove the oblong cutter from the allograft. The saw depth guide and sagittal saw guide are assembled and secured together with the impactor handle and placed into the previous cut made by the oblong cutter. This assembly is advanced until the guide is properly seated to the predetermined depth. A sagittal saw is advanced through the saw guide to create the final cut of the replacement cartilage. The new elliptically shaped cartilage allograft is recovered from the saw depth guide and is placed into a donor trial to confirm the size and fit. The sizer is placed over the marked defect area, and 2 drill pins are advanced through the guide holes.
So this is a living patient.
The sizer is removed, and a scoring device is advanced over the 2 drill pins and tapped into the cartilage to create a perforation. An oblong socket is now created in the knee to match the dimensions of the allograft cartilage. These are made by placing a drill depth guide over one of the drill pins and advanced firmly down against the surface. The reamer is placed over the opposite drill pin and advanced until the strike plate of the reamer hits the depth stop. A box cutter is attached to the impactor handle and is advanced over the drill pins until it stops at the bottom of the newly created socket. The remaining fragments of bone can be removed with the Horwath elevator or small rongeur. The recipient socket is dilated to compact the bone and prepare it for acceptance of the replacement allograft. The dilator will also mimic the fit of the allograft cartilage in the newly created socket. A power pick can be utilized to create a bleeding bed to assist with incorporation. Demineralized bone matrix, or DBM, should be utilized to fill in any bony gaps and to stimulate new bone formation. The replacement cartilage allograft is placed into the defect and a tamp is utilized to assist with properly seating the allograft. The BioUni Oates technique can be combined with an iBalance HTO to correct for alignment issues.
Earlier. Right, so some of the new techniques or more commonly used now techniques for advanced stages of osteoarthritis. Then continuing on with osteochondral allograft, this is just a picture of the allograft coming out of a cadaver that's going to be placed in, and this is a picture of the allograft that is placed in the femur of this patient. This is what it looks like as they're preparing it. There is a very long incision for an OCA that is an open procedure. All right, go take your quiz. It's 10 questions, 10 points about the knee, and I'm going to keep working on my juggling skills. On. Watch this. I got it. Whoa.